Okay, hello. This presentation is going to be on my experience with an inguinal hernia. So this will be from the point of view of an athlete as well as a physio, as I am both. So it might offer a little bit of a different insight to the kind of general public having a hernia and then getting back from surgery. Um, so I'll talk about my previous experience with a hernia surgery, and then I'll also be talking about my experience with my second hernia because I've got a recurrent hernia, and I'm also going to be doing kind of vlogs on Instagram. So after my second hernia surgery on the 16th of December, I'm going to be doing a vlog every day on Instagram to sort of go through my own rehab and getting back into competition after the surgery. Cool. So I'll be talking first about my brief history of my injury, and then sort of how I progressed through diagnosis and then management and surgery, and then rehab after surgery. I'll be defining a hernia, because a hernia is a bit of a vague term. Well, it's not really vague, but it's been misused. I'm just going to define exactly what the hernia is, and then be going through what the surgery is for hernia, and then I'll be going through the rehab and back to competition. But I'll be kind of doing that as one. Uh, cool. All right. So I first had a hernia back in 2018. It was actually 2017 December. I started getting a pain in my groin, and I could kind of feel it when I was running. But it wasn't too bad. It was just kind of there. And then as I trained more and more, it got worse and worse and worse. And then in March in 2018, it got too painful, and I had to stop running. And it actually took me a while to get a proper diagnosis. It took me until August for me to get the correct one, to get actually diagnosed as a hernia. So I went to see loads of physios, and they were saying that it's an adductor tendinopathy. Um, so basically, that's where the adductor in your groin, the muscle that sort of goes down inside your thigh, is has an injury. But I knew it wasn't that, because I thought it was that myself originally, and I did the rehab for it, and it wasn't getting better. Um, so yeah, and then it finally got diagnosed as a hernia. So I then had surgery in October 2018, and then after that I was good to go. It took about 6 weeks to recover, and then you can start to increase your training. In this time between August and October, I did actually do some running, so you can run with a hernia. It's not going to do any damage. Obviously, if you run too much, then you're just going to aggravate it. It's just get more and more sore. So just sort of monitor your running. I was able to run at kind of like 6:30 pace without it being too sore. So that's kind of what I did. And then I got hernia again in 2020, so this year in January. And it's a bit of an annoying story because I went straight to the surgeon after when I started getting the pain, and he said there wasn't any herniation, so there wasn't a hernia. He ultrasounds it and everything, and so there wasn't anything there. And then COVID happened, so I was just kind of stuck in the mud, and yeah, just I couldn't really do anything for a few months. And then I finally went back to the doctor who diagnosed me with the hernia back in 2018. So I saw him in August 2020, and he confirmed that I did have the hernia. And then I went back to the surgeon, who then ultrasounded me again, and he agreed it was the hernia. So I went around in a circle, which is very annoying. But it kind of shows that even though I already had this injury, it got misdiagnosed again. So it just shows how easy it is to miss. So yeah, you people that have this, they'll probably have this sort of pain in their groin, on and off for a few months. They don't really know what it is, and they can't get a proper diagnosis. So if you have that issue, then you could have something like this. So yeah, again, I'm having my second surgery again on the 16th of December. So I'll be doing the vlogs on Instagram uh, day to day, just to show my rehab and recovery after surgery, if anyone's interested in that. Cool. Okay, so defining a hernia. So the word hernia is a bit of a misused word, and it's been used for, you know, many different terms have been used for the same injuries, and then the same terms have been used for different injuries. So I'll try and go through all these terms and clarify exactly exactly what they mean, and be a bit more clear on that. As you can see on the left here, there are going to be some sort of cartoon pictures of genitalia. So if you're not comfortable with that, stop watching. Okay, so the terms. So there's terms that have been used in the sort of general public that you might have heard that are, not very specific to certain things. They may have even been given as a diagnosis from physios that have sort of maybe not used it in the right way. And then it's also terms that have been used incorrectly in the literature, which that actually makes it harder for us physios to understand exactly what these are and how to talk to patients about them. But yeah, so they're normally, the terms you normally hear are umbrella terms. So it's normally an umbrella term for pain in the groin or inguinal region, which is kind of like the lower abdominal groin region area. So things you may have heard are sports hernia, chronic groin pain, sportsman's hernia, sportsman's groin pain, I think that is, athletica pubalgia, Gilmore's groin. Gilmore's groin actually is a specific thing, so it's not really an umbrella term, but people have been using it incorrectly. So people have been using Gilmore's groin for things that aren't actually Gilmore's groin, so it can be misused. And then pubic inguinal pain syndrome, you may have heard. So the reason why hernia is an issue is because it's been used in a condition where there actually isn't a true hernia. So yeah, I'll get onto that later. But essentially, people have been using sportsman's hernia just for groin pain. That actually hasn't been a herniation, so it's incorrect. Okay, so what is a hernia? So essentially, there's different types of hernias that you can get. But I'll be talking about the indirect inguinal hernia and also the direct inguinal hernia and the indirect inguinal hernia. So you can get these in that kind of inguinal groin region there. You can also get the femoral hernia, but I won't be talking about that in so much depth. So essentially, the inguinal hernias are they take place in what's called the inguinal canal. So you can kind of see this little canal bit here, and that essentially is a canal that helps get your abdominal content. If you see the intestines here, out into the front of the body. And the reason why inguinal hernias are more common in men is because you can kind of see that cord there. That's the spermatic cord. So that makes the inguinal canal wider in men than women, which then makes it weaker and more at risk of a hernia. Whereas a femoral hernia is more common in women. So these happen in the femoral canal, which sits kind of there. You can kind of see that little opening. And the femoral canal is vital as it helps the femoral arteries, veins, and nerves go from the top part of your body down into the lower half of your body through that canal there. And the reason why it's more common in women to get a femoral hernia is thought because of the wider hips of a woman makes the canal a bit weaker, so it's more at risk of a hernia. So what exactly is a hernia? So a herniation is something going through a hole or a gap. So if you imagine this line here is the abdominal wall, and then a true hernia is the abdominal content or intestines going through that abdominal wall. So those muscles there, and that would be a true hernia as it's going through. Whereas you can get what's called a sort of an inguinal posterior wall weakness, where there isn't actually a true hernia, but there's like a similar mechanic. So you'd have the inguinal canal here, or the abdominal wall, and then you would have the abdominal content pushing onto the wall. So I might actually just do that again. So it goes down, and then the abdominal content pushes onto it, but it's not actually going through. It's just on the edge and pushing onto it. So So that wouldn't be a true hernia, but I'll get onto what that is in the next slides. But yeah, so this is a true hernia, and that is not a true hernia. Cool. Okay. So to go into more depth in that, to make it a little bit clearer, is to look at the anatomy. Also, I should probably say that these images, I haven't made them. So if anyone's watching this and they've made these images, please don't sue me for copyright. But anyway, so you have different muscles in your abdomen. So you have your rectus abdominis, which is this muscle here, which gives you your six-pack if you don't have fat over it. And then you also have your obliques. So on the outside, you have external obliques running down this way. And then on the inside, you have the internal obliques. And then even deeper to the internal obliques, you have your transverse abdominis here, which kind of sits around your abdominal content. So these muscles here help keep all your abdominal content in position. And then as you can see, this white thing around here is kind of the fascia that link all your muscles together. So you might be able to notice that at this sort of point here, there's no muscle. So it's just fascia. So that is the point where the abdominal wall is at its weakest and where it's more susceptible to bulging or herniations. And as you can see on the graph, the inguinal canal sits there. So that bulging is more susceptible going into that inguinal canal. Whereas if you look in the middle, it's not going to bulge here because there's the rectus abdominis, and it's not going to bulge on the outside as you have the obliques protecting it. Cool. So yeah, that should all make sense. Here's some diagrams just to show that in a different image to make it a little bit more clear. And it also shows you what the difference is between an indirect and a direct hernia. So it's a little bit pixelated, it's a little bit hard to see. But essentially you have these little pink bits here, the muscle. So there's your obliques, so your, internal and external obliques, and then you have your rectus abdominis. And then this bit here is the part of no muscle. So that bit there is susceptible to bulging, and you can see here there's less muscle there. So on this other side for the direct hernia, where I've circled it on the other side, you can see that has the herniation going through there. So this is direct, as it goes directly through the abdominal wall and herniates onto the inguinal canal, and it pushes onto that inguinal canal and causes pain because you obviously have nerves running through there, and then it could also go kind of all the way through and herniate out, and then you'll be able to see the sort of skin bulging. Whereas in indirect hernia, it goes directly through the inguinal canal. So you have this little circle here is the deep inguinal ring, and that's meant to keep the abdominal content from going into the inguinal canal. But if it's weak, then it can go through that ring, and then it will go through outside of the superior superficial inguinal ring, and then it will go down next to the testes. So you'd have your testicles here, and then you would have the canal going down here, and then you'd have the bulging kind of right next to it there. So yeah, so essentially you have, this is like your abdominal wall, and then you'd have your abdominal content here, and then your adductor canal going out there, and then on this side you'd have kind of like your genitalia sitting there, and then you'll see the bulging on that bit here. So if I draw that, you kind of have, that's the abdominal wall, that's your adductor canal, and let's just say that is your genitalia. And then you would have the bulging going through there would be direct, as it's missing the adductor canal, and then indirect would be a bulging going through that canal there. If that is clear. My drawing's awful, so apologies about that. Cool. Okay, so this is another picture just to illustrate the indirect inguinal hernia. So if you can see here, there's the intestines and it's going through the superficial ring, internal or deep ring through the inguinal canal outside the superficial ring, and then it's bulging outside of the body there. And this little section is quite nice because it shows you the spermatic cord, and then these little blue bits, they're kind of like the nerves, so it shows you why it's sore. So obviously, if this big bit of intestine is going through where this bit should be, it's going to put pressure on these nerves and then cause pain. And the bulging is sort of caused by increased pressure in the abdomen. So when you cough or sneeze, all your muscles contract, which causes pressure to increase, and then it pushes your intestines down into that canal. Which is why when you cough or sneeze, you might be able to see the bulging going out, and that's why it's sore when you cough or sneeze. Right, so more pictures. So this one is a bit of very, very simplified picture, but it's quite a good illustration to make it a bit more clearer of a direct hernia. So obviously you can see the intestines there, and then you can see this white sort of capsule on the outside. That is like the abdominal wall, and you can see that little protrusion there is coming directly out of the abdomen rather than going down a canal. Whereas if you look at these pictures here, this is a normal person, so there's no bulge in there because the blue bits are stopping it. And there's no bulge in there as the blue bits stopping it. So the abdominal wall is doing its job. This bit here is the inguinal canal, so it would go like that. So you can see on this one here in the indirect inguinal hernia, it's going on the inside of the oblique, so it's going on the inside, and it's going through the deep ring and then outside the superficial ring and bulging. And then you can kind of see where this is the skin here. You can see as the skin goes out and it bulges and back in. So that's the indirect, and the direct is not going through this bit, so it's not going through there. It's going directly down past the canal, but then it's bulging here. Cool. So that is those were true hernias. So there was 100% herniation there, and you can see it on the skin. But what I had wasn't a true hernia. It was defined as, or it can be defined as a posterior inguinal wall weakness, and its now official name, as by the British media journal, it should be called an inguinal disruption. So essentially, this is what I mentioned earlier. Essentially, what happens is you have your abdominal wall here, and then you have sort of the canal. So let's say the canal's like that, and then you have your abdominal content pushing onto it, but it's not going through. It's just pushing onto it, and then because my abdominal wall's weak, normally my canal should be like thick, so it should be wide, whereas when it's pushing onto it, it's getting thinned, and then that content's pushing onto it, and then the nerves inside that canal are getting squished, which causes the pain. So every time I cough, sneeze, run, that canal is getting squished, and I get pain. So this is the one that was sort of invented, well not invented, but I guess claimed by the doctor, Mr. Gilmore. I can't remember his first name. His first name escapes me. But essentially, he is a surgeon, and he was treating Premier League football players with sort of groin pain, and he discovered this sort of weakness in the duct canal, and he gave them surgery and he fixed them, and then he claimed the name, an injury, and he called it Gilmore's groin. So it still can be called Gilmore's groin, but they're changing it to this just because Gilmore's groin has been used incorrectly, and it's not really that specific. Like Gilmore's groin, it could mean anything, whereas inguinal disruption is a bit more specific to the anatomy and what's going on there. Cool. So what is inguinal disruption? So this slide's kind of everything I've just said, but go into a bit more depth. So there is bulging, but there isn't a true herniation, and you can't see the bulging with your eyes. There's no visible bulging on the skin, but you can see it on an ultrasound. So what would happen is the sonographer or the surgeon or consultant or whoever's assessing you will have a will have the ultrasound scan probe, and it'll put it onto your kind of abdomen, and then what would happen is he'll be able to see all the sort of fascia and muscle tissue with the ultrasound. If you don't know what an ultrasound is, it's basically what they use to scan for like babies. And then when he's scanning you, he'll try and find the inguinal canal, and then ask you to cough. And then if you cough and he can see some bulging or some movement from the kind of posterior wall or the abdominal content going onto the posterior wall, then he'll be able to see that you do have an inguinal disruption. However, this is the gold standard of how to diagnose inguinal disruption, but it's very varied or influenced by the skill of the sonographer. So if the sonographer isn't that experienced or doesn't know how to do this technique, then he might miss it. So obviously you need to find the exact place where there's bulging, and then you need to get them to cough without moving and being able to stay on the same place and be able to see the bulge. So it might take a while for them to actually see anything, and quite a few people might miss it. And this is just the BMJ's asked it to be called inguinal disruption rather than anything else, because previously people have been calling it sportsman's hernia or sports hernia. There isn't a herniation, so that's incorrect. All right, we've gone through all this. Yeah, essentially, so you got the canal, and then you got abdominal content pushing onto the canal, but there's no herniation. Yeah, gone through this, so this kind of shows it. So you see the muscles there, and then the muscles there, and then you got the abdominal content pushing onto that canal, but there's no herniation. Cool. So this is a screenshot from a YouTube video. So again, please don't sue me. Just showing hernia surgery. So essentially, what they do is they cut. Well, actually, before I mention what this one is, there's two different types you can get. So you can get an open surgery, which is this video here, or you can get endoscopic. So endoscopic would be keyhole, so they can put sort of two slits into the front of your stomach, and then about a centimetre long. One would be sort of above your belly button, one would be a little bit low, and they put a camera in one slit, and they put the sort of apparatus in the second slit, and then they can go under your kind of skin into the hernia region and then do the surgery. So this is better than open because you can recover quicker. There's less scarring, there's less kind of trauma, less chance of complications. And I believe it might be a little bit quicker. Whereas an open is, they just cut the skin open and pull it out just like this one here. So you can see they've cut open the skin and all the fascia layer to get to the inguinal canal. So this here is the inguinal canal. And what they would do is for a true hernia, if there was a herniation going through here, they'll push it back up, out back through the deep inguinal ring. If it was an indirect hernia, they'll push it back into the ring so it goes back into the abdominal cavity, and then they'll suture up the hole, as you can see sutures there. If it was a direct hernia, so if it was coming through the actual wall itself, as you can see on this little bit here, there's a little gap there. What they'll do is they'll push that herniation sac back into that space, and then they'll suture it back up. And then what they'll do is they'll put a mesh on this area here. So if they reinforce it with mesh, then there's less chance of it protruding back out because the mesh is kind of holding it back. There's been a bit of controversy with mesh in the past with like pregnant ladies and it causing lots of pain and issues. but in this surgery, it's really effective, and there's very little chance of it causing any kind of risks or complications. But yeah, and then once they put the mesh on, they would put the inguinal canal back into its original place. So they'll put it back centrally, is that a word? Back into the center, and then they'll stitch you back up. So they'll close all the skin, and then you'll get sutured up and down the middle, and then you'll have a nice little scar there. So yeah, so that's the surgery for a true hernia for the two different types. So again, you can have it open or endoscopic. You can have mesh or no mesh. I don't think they do no mesh anymore. That's what they used to do back in the day when they kind of invented this thing. I don't know if it was like in the 50s, I think. But now pretty much everyone uses mesh, and it's more successful. Yeah, and then the anterior approach essentially is always open. So this kind of approach, because they're coming in from the front, whereas a posterior approach coming from behind, they have to do keyhole because they'll be coming from under the skin this way, posteriorly. So my first surgery was done posterior approach endoscopically with mesh, and I went fine, didn't have any issues with it. But this second time, it's going to have to be anterior approach, and it's going to have to be open. The reason being is because the way they've gone previously, there's going to be scar tissue in the way. So if they go back that way, it's going to be harder for the surgeon to see what he's doing, and it also risks other complications because obviously there's less visibility. So it's just a lot easier for him and less risky for me if he goes open at the front and then kind of pulls it out of the way and does the surgery. Cool. So what is the rehab for hernia surgery? So it's pretty good, pretty quick. You're depending on the time of the surgery, it should only be a day case. You'll be in and out. I think average time of surgery is about 90 minutes. It's not a simple surgery, but it's quite a quick one to do. And you can recover pretty quickly. There isn't really any strict protocol you need to stick by. The main thing is just don't lift heavy for 2 to 3 weeks, as it's going to be painful. And it's probably anything over like 10 kilograms is probably going to be quite sore. So the main rule is just basically go off pain. So you want to be able to just do what you feel you can do. So if you go, I don't know, if you lift up something that's 5 kilograms and it's sore, don't do it. But if it isn't sore, then you can do it. You can go back to your normal activity straight after. So don't be afraid to walk. Don't be afraid to go up and down the stairs. Don't be afraid to do the cleaning. Don't be afraid to do washing up, that kind of thing, because you can do it. It's not, if you feel like a little bit of pain, it's not going to be damaging, and the mesh isn't going to be weak straight away. It's it's pretty strong straight after surgery, so don't worry about damaging it. You can return straight to work depending on your profession. Obviously, if you're like a builder or a gardener or something, then you might have to wait a little bit longer. But most of us work in the office these days, so you should be able to get straight back into that. I've always said this, it's kind of pain limiting, so just go as your pain allows. And just for some studies, just to sort of reinforce what I've been saying, there was one study that said that it basically looked at one group of people that did heavy work after 3 weeks post-surgery compared to another group of people that did heavy work after 10 weeks, and there wasn't any difference in recurrence rate. So if you go back to heavy work, earlier than 10 weeks, 3 weeks early, then it's not going to be damaging. It's not going to risk you. There's another study that also found that 75% of people were able to do their own shopping without assistance after 6 days, and most people return to light work or their normal work after 6 days. So most people should be able to return to work pretty soon. Driving's a little bit different because obviously there's insurance that you might have to contact, and surgeon, it depends on what the surgeon's advice is. They all have different sort of advice. But the key thing is that it's pain-free and you're able to do an emergency brake safely. So one study found that 86% of people could have that had an adequate response time for braking after 6 days. After my first one, I can't actually remember when I started driving. I don't think it was as early as 6 days, but I was still in quite a bit of pain, and I don't think it's really worth risking. So obviously, if you can't brake, it's not just your surgery you're messing up. It could be potentially some poor pedestrian on the road. You might give them a hernia, or maybe even worse. Anyway, cool. So if you are a runner, or just someone who likes plans, I know runners like to stick to schedules, and it might just give you a bit more confidence that you're definitely not doing anything wrong. Then here's kind of a schedule that you can use. So essentially, after the first week, just rest and allow the wounds to heal. Like, you are going to be sore, you are going to be bruised. So just relax, take it easy, watch some Netflix, but try and walk as much as possible. Don't be afraid to climb the stairs. And heavy lifting might be painful, and it'd be good to start doing some pelvic floor and transverse abdominis contractions. So if you don't know what these are, then you can go see a physio, or like a Pilates teacher, or yoga or something like that, and they can teach you. But essentially what you do is you contract your pelvic floor and your transverse abs, and just kind of hold it for 5 to 10 seconds, and then relax, and then hold it again for 5 seconds and relax. But how you contract your pelvic floor essentially is you're stopping yourself going to the toilet, or pooing yourself. So you kind of feel, when you're doing right, you can kind of feel that area around your privates sort of going up in, and then you can hold it there and then relax. But that's quite a good initial exercise to engage these muscles after surgery, because they might be a little bit sore after surgery. And then you can also start isometric exercises for your hip. So isometric exercises are basically exercises where your muscle fibers don't move, so they stay in the same position. So if I tense my arm like this, my arm isn't moving, so that's isometric. But as soon as I go like that and bring my arm like this way, my muscle fibers are shortening, so that would be isotonic. So the way you can do this on your hip is to use a wall. So if you want to do hip flexion, you can sort of stand in front of a wall and then push your foot into the wall. If you want to do hip extension, you can stand with your back against the wall and then push your heel of your foot into the wall. If you want to do hip abduction and work your glutes, then you can stand sideways on, bring your knee up, and then push out into the wall. Or you could do it with straight leg and push in. It might be more comfortable to have your knee up and then push in. And then if you want to do hip adduction, so that's working your groin, it might be worth doing it sort of standing sideways onto like a door or something, and then put the inside of your foot against the object, like a heavy dining table might be quite good, and push your foot in. But yeah, that adduction might be quite painful to start off with, so just be careful on that, and as well as the flexion. Those two ones will maybe be painful. So after the first week, you can progress onto light core on your second week. So for these exercises, you progress them onto doing contractions where you kind of move. So you can do that pelvic floor contraction while moving your lower limbs. So you could lay on your back and then have your legs kind of crooked up, and then just drop your knee out and bring it back in. Or you could do it like extending your leg out and bringing it back up. Yeah, if you have any questions, you can get a physio. And then you want to progress your walking as much as possible. So yeah, just go for long walks. Go like 40-minute walk or whatever you can tolerate. And then it might be a good idea to go onto a stationary bike. So I'd suggest a stationary bike, because if you go onto a normal bike, if you fall off, especially if you've got clip-ins, then you risk hurting yourself, and especially the wound, and that kind of trauma could actually cause a bit of damage that you wouldn't want to do. So yeah, get onto a stationary bike, put the resistance nice and low, and just go for like 5-10 minutes, and then progress it slowly each day. So week 3, that's when you can kind of start to get back into normal exercising. I think last time, I think it was about the 3rd week that I started doing jogging. When I say jogging, it was really, really slow. And I only did about 1 minute to start off with, and I built it up, kind of like a minute or 2 each day. So I did, the first day was like 1 minute, and then the second day was like 2 by 1 minute, and then 2 by 2 minutes, and then like 3 by 2 minutes, and then 2 by 3 minutes, and then 2 by 4 minutes. And I kind of like progressed up like that. And then for your exercises, you can then start to include what's called a TheraBand. So they're the sort of elastic bands that give you some resistance. And yeah, if you just kind of put them around your foot and then like maybe a table, and you can use them to work your adductors or abductors and your like glutes and stuff like that. But yeah, you can kind of get exercise like that off a physio. Cool. And then week 4, which is up here, that is when your pain will probably be, oh god, what have I done there? That's when your pain will be massively reduced, and that's when you start to feel pretty good. And then at this point you can start progressing your aerobic running quickly. So you can start getting back up to like the 20-30 minutes of running if your pain allows. If obviously it is painful, I wouldn't suggest doing it just because I said, but you probably will start being able to run a lot more. But I think it's always best to not run conservatively, just to be safe. You can start doing some light lifting in the gym, so you can just practice like the motor patterns or the movement patterns and not really putting much weight on. So just do like a bar or something, just to get back into doing the like really light squats and deadlift movements. You may be able to start swimming. You might actually be able to start swimming a little bit earlier. The thing with swimming is when you're doing front crawl, you're stretching your stomach quite a lot, and when you're stretching it, that can be quite painful. Also, if you're in water, you might there's always a risk of getting infection in the wound. So make sure your cut is always, or not always, but make sure your cut is fully healed, and it's not too painful to kind of reach up. If that's okay, then you can start doing some swimming. And just progressive cycling as able. And then at this point, you can sort of get to do more functional core. So you can do more core exercises in different funky positions. I don't know if you want to try like a plank or something. And then it's really, really important to make sure you focus on your adductors after hernia surgery. The reason being is there's a theory with the mechanics of the hernia is that the ratio between the strength of your core muscles and your adductor muscles are off. So if your adductors are strong and your core is weak, then your adductor is going to be pulling on that inguinal canal and weakening it, and then causing a weakness where there could be a bulge. So you want to make sure you strengthen all of it, so it's there's no sort of misbalance in this sort of key area around your groin, because that could be a risk factor to getting a second hernia. And then also strengthen your glutes as well. So week 5, so that is when you can start to increase your intensity. So you should be able to start doing some early sprinting. I didn't do full out sprinting until months after, but I was doing cross country training, so I started doing some like drill exercises and stuff at week 5. You can start doing some changing direction drills. So if you're a footballer, you can get some cones out and do some changing direction exercises, which put more strain on that groin, but by then you should be able to tolerate it. And then once you get to week 6, that's when you can kind of return to normal training. Because I think by week 6 last time I was doing sessions. That's when I did my first session after 6 weeks. And then you want to do your normal graded returns activity. So this is where you risk thinking, right, it's been 6 weeks, I'm just going to jump straight back into training as I would before, and then what you end up doing is getting an injury elsewhere. Because when you haven't been running for the 6 weeks post surgery and then however many months before surgery, there's that risk that you just get a bit too excited and then overdo it. So the way you can kind of get around this is set a training plan before your surgery. So if you do that, there's not a risk of you just trying kind of doing whatever you want after, because you're going to stick to that plan. So what I kind of did is I had a race and a date in mind in the future after the surgery that I was aiming for, and then I set a training plan up till then, that I stick to. It didn't really matter how I felt. If I felt amazing, I stuck to the plan, and yeah, I didn't get injured, so it worked. So yeah, if you're one of those compulsive people, then it might be something to think about. Cool. All right. Risks. So what are the risks of a hernia surgery? So the risks are relatively low. Well, the risk of complications are relatively low for this surgery. Obviously, there's side effects that you have after surgery that you should expect. So the main one being pain. So I was in quite, at the start for the first week or two, I was in quite a bit of pain. I had a lot of swelling, a lot of bruising. My stomach was, distended, and I actually had a bit of swelling and bruising in a bit of a private area. So I won't get too graphic, but me and my girlfriend had a good laugh about that, and it was quite it was quite sore and painful. So if you do have that, don't worry. So it's quite a common thing, and it happens in everyone, and it normally settles down after a few weeks. But yeah, it did look very weird having swelling in that area. Anyway, you can also get constipation and like urinary retention. I think my first wee was pretty painful after, and then for a few days, it sort of came back to normal. But I did actually have constipation for quite a while, and I think the reason being is your muscles that help you obviously go to the toilet are really sore and weak. So when you do sort of push, it's painful, and then also the anaesthetic can induce constipation as well. So yeah, my constipation lasted quite a while. I think it was like 1 or 2 weeks. So don't get too stressed about that. You can also get hematomas, so that's kind of like blood sort of sac kind of things that could build up around the area, and seromas, which is just like a fluid sac that builds up. It's actually quite a high percentage, like 8 to 22%, so it's quite a high percentage. But these normally kind of just go on their own. If not, the surgeon can normally do quite conservative management to help settle them down. There's very, very few cases where hematoma can be very serious. But yeah, I think the risk of that is very low. So the overall incidence of having chronic pain is about 10 to 12% post-surgery, and that sounds quite high, but if you think about how many people actually have hernia surgeries, it's thousands. It's like one of the most common surgeries out there, I think. And it also depends on the surgeon's skill. So if you get an experienced surgeon, that would be less than 10 to 12%, whereas if you have someone that's new, or just a poor one, then it could be a little bit higher than that percentage. But yeah, normally most people don't get chronic pain after. I did get a recurrent issue, and that isn't very likely either. But my recurrent issue wasn't actually that bad. So it's painful, but only when I train loads on it, like when I'm doing lots of sessions on the track and doing high mileage. But if I was to be a normal person that just goes to work and sits down after work and not do anything, it wouldn't affect me at all. I can sit here on the chair and not feel anything. I can go cycling and not feel anything. So recurrence isn't really a big problem if you're not a sports person. There's always risk of damaging the inguinal nerves, because obviously the nerves go through the inguinal canal. And if you get damage there, you might get some kind of numbness or like weird sensations in your thigh and groin, which could be quite uncomfortable. These sensations can also be triggered by mesh irritation. So if the mesh has kind of got scar tissue all around it and it's not healing properly, and that can then irritate the nerves, and then give you kind of the neural sensations of pins, so like numbness and like pins and needles or like burning sensations. There's also a risk that the mesh could move, but yeah, I don't think that's too likely. And then there's always the small chance of internal organ damage. So obviously you've got surgery going on directly above it, so but that's quite low. Cool. So inguinal disruption surgery. So it's pretty much the same thing. So they can do keyhole or endoscopic, and then they find the posterior wall weakness, and then they put a mesh on it, and then they suture you back up. It's the same sort of recovery time, and it's the same sort of protocol. Yeah. However, so if you look at videos on YouTube of Mr. Gilmore or the surgeon, someone Gilmore, I can't remember his name. They talk about muscles that can get strained and torn in this injury. So basically, you have the adductor muscles there, and then you'd have the sort of abdominal muscles here, and then you have that sort of adductor canal here. And it's very common for this adductor muscle to get strained with the inguinal disruption, and it's also common for the rectus abdominis and oblique muscles to get strained there. And what can happen is if they get strained, so you got the two muscles here and the canal going through, they may open up and widen, and then that makes it weaker. So there's more chance of a herniation. So what they can do is kind of suture them together and bring them back in to stop that from happening. And then what they can do is operate on the adductor muscles as well to help heal that strain. I don't think I had any of those issues, but yeah, that's something that the surgeons can do, depending on what the certain technique that the surgeon uses. There's also another thing that some surgeons do is where they loosen inguinal ligament. So right next to that inguinal canal, there's an inguinal ligament that runs up here. And if that is tight, it can increase the pressure in that area. So what they can do is just kind of cut the little bit that attaches onto that pubic bone, which then loosens it and then decreases the pressure. But it's quite invasive. I think that's more common in kind of footballers where they need to get back quicker, and or if someone's got recurrent inguinal pain. So I've had it twice. If I get it for a third time, it might be something that I could consider to help stop it coming back again. Cool. So how do you know when you have inguinal disruption? What are the signs and symptoms? So from like a physio point of view, this is the diagnosis protocol that is made by the British Hernia Society. So essentially, you have pain that's sort of dull and diffuse, and you can't really pinpoint it to exact place, and it kind of radiates down your groin, inside your groin, so the inside of your thigh. There'll be tenderness if you poke on the pubic bone, so that sort of hard bone above your private area, and then there'd also be pain on that kind of inguinal ligament where the inguinal canal sits. You'd also get pain if you palpate the adductor longus, so that the groin muscle that helps to bring your legs together. And then this is a clinical test that medical doctors can do that assesses the superficial ring of the adductor canal. So I don't know if you remember me talking about it, but it kind of sits here, and then the cord kind of goes out of it. So this is the superficial one that's outside. So you'd have the kind of the testicles here, and then what they do is they put their finger up into that canal to feel the pain that will go up like this. So you'll be sort of standing up, and then they'll put their finger next to your private area and try and find that canal, and then put their finger into it. If it's painful, or if it feels like to their finger, if it feels like it's dilated, then that could be a sign. And I can tell you it isn't very pleasant. So what are my actual symptoms when I had this inguinal disruption? So I had pain when I coughed, when I sneezed, when I laughed. So basically anything where my core was like tensing, sort of involuntary, and increasing the abdominal pressure, which then causes the pushing on the posterior wall. Sports when change direction, so football hurt, playing frisbee. Running was worse when I was running quicker, so I could jog okay. Now I've sort of strengthened up myself so I can run pretty quick without pain. But when I first got it, like running 7 minute miling was okay, but anything quicker than that was sore. And if I did anything like more training, it just got more sore. It was really sore in the morning, so this was a strange one. So I kind of wake up and then I'd get just like really shooting pain down my groin. I think it was probably because it was stiff in the morning, and then I would just like jolt around as I'm waking up, and it would cause like so much pain, and it would last for about 30 seconds, and then I'm out of bed and it's fine. But if you have that, then that could be a sign. Quick sudden movements. So I remember I was walking forward and I went to turn around, and then someone was behind me, and stopped myself from walking into them. I kind of jumped backwards, and then as I jumped backwards, that sent like a proper sharp shooting pain right up my stomach. It was so painful. Um, so yeah, so if you get that kind of thing, then that could be a sign. If you get pain, as mentioned before, going down your inside of your groin, then that could be a sign. So I think this was a bit of a red herring for the physios, I thought, because they just sort of identified I had pain in that area and then concluded I had adductor tendinopathy. Whereas I did actually have pain here as well, but it just wasn't as bad. So I had pain in that inguinal region where the canal sits, but it wasn't as bad. So they kind of missed it. So if you have pain in the adductor, it doesn't always mean it's adductor tendinopathy. You have to make sure you clear all the other areas in the groin so you're not missing anything. And the last one is pain of hip abduction. So when I don't know, so say if you're just like squeezing something between your knees, that would be painful. Right, so differential diagnosis. So these are things that it could be that's similar to the pain that you get, and the physios or medical professional needs to rule out. So you can have you can have pubic instability. You could have osteitis pubis, so that's kind of like inflammation of that pubic bone. You can have adductor strain tear tendinopathy, as mentioned before, so the injury to your groin muscle in the inside of your thigh. You can have impingement, so this is where you have so basically you have your femur. I'll draw on the screen. So you have your femur bone, so your leg bone, and then you'd have your hip socket that sits around here. So that's your hip socket. And then around that socket you have like a cartilage that kind of sits like that. So the cartilage kind of helps it stay in place. But as this bone moves upwards, so as it goes like that, the cartilage can kind of get a bit impinged, which then or it's not really, it's called the labrum, would get impinged, and that will cause pain. So yeah, so it could be that. It could be a hip flexor strain, so the muscles that sit in front of your hip. It could be pain resulting from those muscles. You can get something called a snapping syndrome. So I actually have this, but it doesn't cause me issues because it's not painful. But basically, your hip flexors sit over a bone. They sit over a bone in your hip, and then as you move your hip up and down, the tendon kind of flips over that bone and causes a snapping sensation. So for me, I get the snapping, but it's not sore. But for some people, that snapping could be really painful if the tendon's kind of like inflamed and irritated. So yeah, it could be that. You could get a rectus abdominis strain. So as mentioned before, so you have your pubic bone, your adductor muscle, your inguinal canal, and then your your rectus abdominis sits there. So you could have a strain in this, part here that's causing the pain. Or if you're elderly, or not elderly, like 50 or older, you could have hip OA. So that's arthritis of the hip. So if you feel like stiff and sore in the morning, then it eases off, you walk around. It could be that. Yeah, cool. So to summarize, essentially, the terminology for inguinal disruption and inguinal hernias are messed up because it's all confusing. But yeah, the sports hernia isn't good to use, so don't use it. There's no herniation unless you have a true inguinal hernia. So it's either inguinal hernia or inguinal disruption. Many therapists miss this diagnosis as there is no bulging or there's no visible bulging. So yeah, you might find yourself going round and round in circles. Surgery is most likely needed for sporting people, but it isn't vital for the general population. If you're not active, then it might not be affecting your general your everyday life. So there might actually be loads and loads of people that have this that don't realise. But yeah, surgery is pretty successful, and it's a very quick recovery. So yeah, so I wouldn't say I wouldn't say you need to be scared of surgery. I think it's quite good. You can still run while waiting for surgery. It's not going to damage it anymore. Just make sure you don't aggravate it, because once you aggravate it, it's really hard for it to settle down. So yeah, you can still run, but just jog and keep the pain levels low. And then after surgery, don't forget to strengthen the adductors as well as your core muscles. And that's it. Cool. So make sure you look out for the Instagram stories after the 16th of December, because on the 16th I have my second surgery, and then every day after that I'm going to be doing videos for kind of like my recovery and how I'm going to get myself back to running and then back to competition. Cool. And if you have any questions, you can always ask me stuff on social media. Yeah. Sweet. See you later.